Hi, everyone. For those of you who I haven't met yet, I'm one of the pediatric oncologists at Dana-Farber and Boston Children's, and I have the pleasure of and the privilege of helping to care for and walk alongside many families with LFS and other cancer syndromes in our pediatric cancer genetic risk program. So I wanted to thank David and Jen and Holly and all the organizers of this amazing conference. I have to confess, yesterday I was feeling a little bit under the weather, but it all turned around when I ran into one of my very favorite families in the lobby, and it just made me feel great. The idea that sort of all of us are coming together from so many different places toward one common goal is really very inspiring. So I promised to talk about our experiences at the Dana-Farber with cancer screening. My one caveat is that I'm very pediatric focused because of where I come from, though I will try to also show you some of the adult data. So following on the footsteps of our PET scan study led by Junne Kamihara and work from David's group and others, in 2011, we started what is now a multi-institutional surveillance study that incorporates MRI, whole body MRIs, for children and adults, initially for LFS and now also for other cancer predisposition syndromes. The overall study PI is my colleague and friend, Ali O'Neill, who's one of the pediatric oncologists in our group who has a specific interest and expertise in using different imaging modalities for detecting cancers. And of course, Stefan and Jyoti are our fabulous radiologists who have put a lot of effort and thoughtfulness into this project, and Judy and Lisa, who have really trailblazed in cancer predisposition in Boston. So now we have a prospective cohort from Dana-Farber with a collaboration with MSK, and CHOP has recently come on board as well so that we can really work together toward these questions. So in our study, the initial goals were to assess the feasibility of incorporating whole-body MRI into surveillance programs, and I was very careful about the language I chose to say that because in addition to whole-body MRI, as you've heard, we also recommend other physical exam, close attention to signs and symptom, labs, and other studies in between. So for pediatrics, with some tweaking, we basically follow the AACR guidelines that you've heard about that have been recently published that incorporate modalities like ultrasounds, of the abdomen, as well as other aspects of screening. And for the adult side, for example, breast imaging that's dedicated, recommendations for colonoscopies, et cetera, are also incorporated to the whole screening regimen. The one difference that we have in Boston is that currently we use a single non-contrast whole-body MRI, so we don't actually do a separate brain MRI, and the reason for that really was because when we first started out, we wanted to do something that was simple for the patients, not necessarily adding more imaging, more time, and I'll show you some of the data of what this looks like for us now. We do have a separate neuroradiologist, though, who reads every scan and sort of reads the brain spine imaging from the whole bodies. So for our study, I pulled out the Dana-Farber cohort, and I pulled out the people who have completed at least one scan. Some of the earlier data has been published by Ali in PBC, and we've also contributed data toward the JAMA Oncology meta-analysis that you've heard about. But of the 102 patients, we have 74 adults and 28 children, so I'm going to talk about them. So of the 28 children and 74 adults, the median age for our kids was around 8 years old. They range from 14 months to 17 years. On the adult side, the median age was 41 years old. We have basically a 50-50 male and female in the pediatric side, although on the adult side, similar to many studies that we've heard about this morning, they're predominantly female with 76%. I think in our setting that could largely be because of the breast imaging and also just what we see in genetics often. Prior histories of cancer, this is a really important category that I want to bring your attention to and we'll talk about soon. But in our pediatric cohort, really the majority have not had previous cancers. So 79% came into the study without having had previous cancers. But it's the opposite on the adult side where 68% have. This is the number of scans each of the cohorts has completed thus far. So about 30% or so has now completed 4 scans on our of the children, and on the adult side, about 40% have completed 3 scans. So our follow-up on the pediatric side is about 3.5 years, with a range that goes to 6 years and approximately to 7 years on the adult side. And here are the results. So on the pediatric side, the number of participants who have needed sedation is 19, so about 68%. We recommended follow-up in 11 patients, of which 8 of them have completed follow-up thus far. Only one patient actually had a biopsy that was recommended, and I'm going to show you that soon. And no one thus far has had a biopsy-confirmed cancer diagnosis. And in addition, we have 2 neoplasms that we're sort of presuming based on imaging. On the adult side, there were 35 people who had 48 studies for follow-up that were recommended, and one participant actually had 2 biopsies, and with a total of 19 biopsies total that were done, and there were 6 cancer diagnoses in 5 people on the adult side so far. So first, on the pediatric side, I mentioned that one of our participants had a biopsy, and that was because of this 9 by 7 millimeter lesion that was initially detected on the whole body MRI scan, which is the panel that you see to your left. On the follow-up dedicated MRI of the brain, which you see to the right, we saw the similar lesion. And we actually monitored this lesion for several years with surveillance imaging for about 2 years, and the lesion remained stable. But then after that point, sort of after lots of multidisciplinary discussions with neurosurgery, with neuro-oncology, with the family, importantly, we decided to do an excisional biopsy. And actually, the pathology showed gliosis, and this patient is actually doing wonderfully right now. We have 2 additional lesions that we're presuming to be neoplasms that were found by imaging. One is this 3 millimeter lesion in the globus pallidus for one of our participants. So this was actually found on dedicated brain MRI, which he was getting because he was getting that for follow-up for a previous choroid plexus carcinoma that he had had. And when we went back and looked on the whole body MRI 6 months before, we don't actually see the lesion, but we do see it subsequently on the MRI 6 months later, and the whole body MRI 6 months later. So we presume that this likely arose sometime between that whole body MRI and then the dedicated brain MRI. And we've been following this lesion very closely, and it's been stable now for about 1 year and 7 months, almost 2 years. More recently, we had another patient who had a 4 by 5 by 8 millimeter lesion that was noted in the cervical spine on whole body MRI. And this was actually a good case to show because the neuroradiologist who was sort of watching the scan as it was happening noted that there was a little lesion in real time and called us and said, you know, it would really be helpful in this particular case if we could have post-contrast imaging. And so that's what we did. And sure enough, there's this lesion, and clinical follow-up is pending for this patient. So we thus far haven't had any pediatric high-grade malignancies in this study, and you might be wondering why. We wondered that as well. So part of the issue, of course, we've heard a lot about how mutations are ascertained, and this is where, when I talked about 79% of our patients came into the study without actually having cancer, and if you think about how their parents might have been diagnosed by panel testing and otherwise, this may play into it. Of course, we've talked a lot about issues such as penetrance and heterogeneity, and so those may come into play as well. And we've talked also about modifiers, and there's one particular modifier that I wanted to talk about for this cohort from Boston, and that is, it's environmental. But when you live in Boston for a long time as a diehard Red Sox fan, you are subject to a lot of abuse, especially when you go to other cities. And so that leads to potentially epigenetic changes that makes you of hardier stock and resistant to childhood cancers. It's a hypothesis. This is the adult data from the same study. So we found 5 cancers, or 6 cancers in 5 people: thyroid cancer, lung cancer, pelvic leiomyosarcoma, and an astrocytoma in 1 individual, chordomal of the clivus, and pancreatic cancer. And as you've heard from other studies as well, we are also finding additional malignancies in the interval between scans, either by other modalities or by symptoms. And for us, these have included so far serous adenocarcinoma of the endometrium, metastatic adenocarcinoma of the breast, metastatic adenocarcinoma that with lung origin, sarcoma of the chest wall, and a DCIS. So bringing this all together, our conclusions are, yes, that whole body MRI has been quite feasible for us to incorporate into surveillance programs. We have done now a total of 253 for these LFS participants from the Dana-Farber, including the 28 kids and 74 adults. The majority, as you heard, have had follow-up studies. We've diagnosed 6 cancers in 5 adults by whole body MRI, and 2 presumed neoplasms in children, of which 1 was seen first on whole body MRI. The neoplasms that were detected in the interval between scans, I think, provides further evidence that whole body MRI alone is not sufficient as a standalone for surveillance. So you've heard a lot about numbers this morning, and so I just wanted to offer in some of my perspective as a clinician about surveillance and the things that I've been learning from my patients about surveillance that extends beyond all these numbers we've been seeing. So the first thing is that this journey, and it's definitely a journey of going through surveillance, is a partnership, and it's an important partnership and a bond that we form with the clinical team and with the families, and we spend a lot of time talking about what their hopes and expectations are and their priorities, and which brings me to the second point, which is that everyone really comes in with a different lens through which they understand cancer risk and surveillance. And I have a case example that highlights this. So this is one of my wonderful teenage patients who had a pelvic rhabdo at age 3, followed by an osteosarcoma at age 7 in the radiation field. That was then recurrent at age 11. And then he was having some loose stools, and everyone was wondering why, and it ended up being a colon adenocarcinoma. He had an initial resection, and then he had residual disease that was found, so then had to go back in and have another resection. I'm happy to report that this is actually quite some time ago, and he's doing very well. He's super brave. I didn't ask him if he was a Red Sox fan. I should have done that. But you know, I sat down with him and I said, "This is what we're gonna talk about, this surveillance, and it incorporates whole body MRIs and all these other modalities." And he kind of said, "That sounds great, Dr. Junne." You know, he was totally fine with it, given his history. On the other hand, I have this family who I love very dearly as well, with a little child who was diagnosed, not in our institution, with a cancer. And the way that the family remembers being diagnosed with LFS or hearing about the TP53 mutation is that a trainee came in sort of in the middle of the night and said, "We need you to sign here to consent for tumor testing because hopefully it'll help with treating this cancer," not really knowing or thinking about the fact that this could have germline implications. And for this family, the germline implications was the finding of a TP53 mutation. And so therefore, this whole journey into P53 and LFS and surveillance and cancer risk was completely new and quite a different path than my other patient. The other thing I've learned from families is that everyone's understanding of how we tolerate risks and benefits is definitely unique. I think for some families, this risks of false positives is not as tolerable as for other families. And I think it's something really important there to explore. And risks of sedation, I know a lot of our pediatric families, definitely this is on their mind, especially with some of the newer information that's coming out or the newer data that's coming out. So what does this mean, having to undergo these scans and going through sedation, et cetera? So I think these are very important points. So remaining questions are, as you've heard, as our understanding of genotype and phenotype in LFS really broadens, this brings a lot of layers of complexity into surveillance as well. And so how do we bring that into our approach to surveillance? And how do we evolve to provide accurate personalized surveillance recommendations? It seems like a lot of us are thinking about this and along these lines. For me, this last point is something I think a lot about. So how do we resolve this tension between wanting to be really proactive about screening? I mean, certainly as a clinician and, as a parent, you don't want to miss a cancer, you want to find it before it's aggressive. But at the same time, you saw that a lot of our pediatric cohort are currently unaffected. So how do we help an asymptomatic child just be a kid and not necessarily turn them into a patient? And so I think that's something that we think a lot about, and I'm excited for the future when they could just get their eyebrow plucked at home instead of having to come in and see us so much. So I would like to thank all of the people who are involved in this whole body MRI study at the Dana-Farber. Of course, Judy and Lisa are my really amazing mentors. The LFSA was very supportive of the study, and of course, all of our families. Thank you.
Thanks very much, June. So maybe a time for another question. Sharon. Yeah.
Well, thank you. That was a great talk. I was a little confused. Your conclusion was that a majority had false positives, but it's like 40%, right? So just wanted to wordsmith that. But I was curious, do the same people, because you had data on multiple screens, so do the same people often have multiple, the second round again having other false positives? Or is it just tend to be random who each time winds up with a false positive? Because
I think I understand.
I have to say, listening to this morning, I came out of this morning kind of much less in love with whole body MRI than I started the morning, between the French study and all the data everyone's showing. So I'm just curious kind of what the experience over time, since you had a number of people with multiple scans.
Well, so especially from the pediatric perspective. So I think there's two issues here. I think we definitely have a similar issue to what we've been hearing this morning, in that the definition of false positive, I think we all have to come to an agreement. And so the numbers that I'm showing here, so on the pediatric side, this includes people who have had follow-up that were recommended for suspected malignancies, but also for other reasons where we felt that a follow-up was important for whatever reason. On the adult side, actually, so I wanted to simplify things on the adult side. On this particular number, really, when we looked at the data, was more for people who had follow-up for the concern of a neoplasm, not all of the people who had some kind of finding by looking. So if you look, you will find often. And so in order to simplify it and think about it from a neoplasm standpoint, when I say majority, it really was the majority had false positives in the sense that they weren't things that we set out looking for. This number on the adult side is the number who needed follow-up studies because of a concern of a potential neoplasm.
Got it.
On the pediatric side, because we're a little bit simpler, this is the number who needed follow-up studies for things we felt like follow-up studies were worthy of. So for the two patients who didn't have follow-up studies, in this case, actually were for other reasons that were not concerning for neoplasm, and they've been doing fine more than 3 years out of the scan.